Everyone back to our Secretary's Advisory Committee on Infant and Maternal Mortality. We hope you had a wonderful evening. I know many of us have been talking about food ever since we got here, apparently. We had a great evening, so again, hope everyone has enjoyed their time. We can definitely say that St. Louis has rolled out the red carpet for us with their wonderful hospitality and have given us the opportunity to be engaged with all types of people. And I think yesterday we had another good, wonderful day, and I think it was really capped off late yesterday afternoon by our Community Voices panel, and we had the opportunity to listen some more to what individuals with lived experience, people who live here in this community, who work with the topic areas of infant and maternal mortality. We were able to get their perspective on how do we address Black infant and maternal mortality. And so I know that was a good experience for all of us. And I think yesterday morning, many of us were able to again participate in the social determinants of health tour. And even though we talk about social determinants of health, and many of us, this is, what we've been talking about for quite some time, being able to actually see it in a community and actually feel it and be part of what families are dealing with, really help the committee to start thinking through what some of our recommendations may be. We have a pretty full agenda this morning, but we're going to try to move it along because we know several of our committee members have flights that are going out today that will need to leave a little bit early. So I'm going to adjust the agenda just a little bit. We will come back to the American Indian and Alaska Native recommendations, because at this point, I want us to really get into our follow-up discussions from our work groups yesterday. So yesterday, all three of the work groups were able to share and provide a really nice update on the status of the work groups and what has been occurring in the various work groups. We were able to hear from social determinants of health, from our systems around rural health, as well as our preconception, interconception. And each of the work groups came back to us and said, we've got a couple of questions, things that we want some feedback from the larger group before we move forward. And so I think that is very important for us to take that time this morning. We're just going to adjust the schedule a little bit and move that up so that we can have everyone there. As a reminder, this morning we have two of our appointed members that are joining us virtually. Marie Ramos, as well as Sharonda Thompson, is joining us virtually this morning. And then we have the others that are in the room, and we have other guests that have come by today to see us from the HRSA Region 7 office. So wonderful to see you all. I know we have many ex officio members that are also joining us virtually. If there are any ex officio members that are joining us virtually and you've not had an opportunity to introduce yourself, it will just take one moment so we'll know who else is there with us. So if you've not introduced yourself either on Tuesday or Wednesday, I'm going to the list to see if I can figure out if we missed anybody. Is there anyone? Let's see. Maybe everyone has introduced themselves. Or you're being shy today? So Christine. Kristen, I recall Kristen, did she introduce herself? Yeah. She did, okay, thank you. All right, moving on then. Back to our work group discussions. So we're going to go now to our work group leads again, because I want us to really go back and think of the questions they asked. And this morning, I think we will start with our preconception, interconception team with Phyllis and Joy. And if we think back to the question that they asked us to focus on and to think about last night. Ladies, do you want to remind us of your questions?
I think we asked about were there specific issues for rural families, Black mothers and families. That was one. I think were we missing anything? And I think the third one was specific issues for Black and moms and babies.
Thank you. So I know when the question was asked, what are we missing? I think one of the areas we talked about was misinformation around contraceptive services or just contraception in general, family planning. I think that was one of the areas that we brought up yesterday. But are there any specific areas, and we're opening this up to everyone around rural communities as we think about preconception and interconception care?
That's one thing that it will be, overlap, I think, certainly, since with our work group of theme, that will affect all really is, if we're thinking about rural areas and even not rural areas, is access to information that's delivered through the web or, text, really broadband availability and that sort of thing, and how that limits and can potentially, as we move, so much communication is moving toward that mechanism, the concern that can cause a further divide in disparities. That is something I'm not really well versed in. If we, this committee in general needs to learn more about what that is and what recommendations we could put forward. It seems to me to be an important overarching theme.
Are you thinking more along in rural communities having limited access to just technology? Poor internet access, things of that nature.
Yeah, technology, it could be hardware, it could, but I think more, at least I'm speaking from my experience, it's more access to internet.
Actually, that's an issue that crosses urban and rural, because we learned in the pandemic, cities like Baltimore, major cities, there are certain neighborhoods that just didn't have broadband access. So I think
I was sharing with Sean, we were talking about it yesterday. I was sharing with her that when COVID hit, the children across the street from me and I live in Chapel, and had trouble with accessing their schoolwork, because we didn't have cable, in our neighborhood. So I just think something we should, it has a potential of if we move to, as the world is moving to more electronic communication and seems to be preferred by young people in the listening sessions that we're doing for other work, yet it has that risk of making things worse.
And then maybe we can get a speaker from, I know many of the states have like rural health programs that are looking at broadband access, but I don't know on the federal level, is that coming out of the Office of Rural Health? Is there someone there that we can get a speaker that can give us an update or figure out where that resides?
Either the Office of Rural Health or FCC. I mean, FCC's got a major broadband initiative. FCC, federal.
Oh, thank you.
and along with that too, I think we have to understand, there's a myth that vulnerable populations don't have access, but many of them use it through cell phones and not, laptops or TVs or that kind of thing. So I think as we think about this going ahead, that's something to give consideration to, how we deliver the information, and that over and above telemedicine, just the broad of telehealth is going to be a way to deliver a lot of information.
Wonderful. Maria, I see your hand is up there.
Good morning, folks. Thank you, Belinda. I'm glad that we brought this up. Certainly broadband, and I was just about to put this comment in the chat. I know that I have been speaking since the pandemic of broadband access as being a social determinant of health. I'm not sure of the formality of that reality in the terms of social determinants and health disparities. I'm curious, I know someone said FCC. I'm curious to know if there would be another presenter or representative that could give us more insights on that, particularly as it relates to not only interconception care, but perinatal care with remote patient monitoring. That is huge as it relates to our patients that have gestational diabetes or who are hypertensive and pregnant. So I'm curious if the larger group would benefit from hearing from an entity that can speak to specifically broadband access, what's currently being done to expand broadband access, and this concept of broadband access being a social determinant of health. And I completely double click on whoever said this is not just a rural issue. This is very much an urban issue as well, because we saw it during COVID that in urban settings, there may be broadband access, but access to devices is limited and can get in the way of continuity of care as well. So some households may have one device that they can use, and we definitely saw that on the education side. So I'd love to hear, in addition to FCC, can the committee get an idea of what current federal programs are available regarding broadband access for states to take advantage of, and whether we can recommend to the secretary to expand that for higher HRSA score areas, for instance, so that pregnant persons can also have that as a resource.
Thank you, Marie. I don't see people not supportive of that at this table. I think all of us will definitely be supportive of trying to make sure that we can get someone from either the FCC, from Rural Health, someone to talk about the larger issue. And it was Phyllis that brought up the issue that is beyond rural areas, Marie, just to make sure you know that. And
Thank
it
you,
looks
Phyllis.
like, thank you. It looks like Caroline put in the chat information about what USDA is doing on this work.
Great, that's what Nancy just mentioned as well, USDA, and then we wanted everyone to be aware of HRSA's funding of the Telehealth Resource Center program, so I'll put that in the chat, but we can look into all of these in terms of potential speakers or what can be shared, and I see Caroline is on screen.
Carolina, did you want to say anything about what you put in the chat?
I was just going to say, I am by no means USDA's expert on rural access to broadband, but I am happy to connect with our expert if that is something that is desired. So just putting that out there from the USDA side.
Thank you so much.
And I think from an action-focused standpoint, it would be really interesting for us to know what already exists. And then we can suggest to the secretary, can this be expanded, particularly for pregnant persons and peripartum persons, so that we can ensure that they have access for services no matter where they are. So that's my thought process, thinking more forward.
I think we should be able to work, but hopefully get someone willing to present in June for our meeting in June. And that way we'll open it up to everyone and not limit it to a specific work group. Because it does appear to be crossing everyone.
That's what I was hoping for. Yeah.
Yes, Jacob.
One layer I wanted to just add on top of it as we think about it is Frontier, where when we're talking broadband access, there's no cell service. So that we can't just anchor it on to cellular service. So we might need to think about satellite app. I was thinking to Marie's point, if we want to have programs that are providing broadband to pregnant people, we might have to think about satellite, because when I drive to Casper, I have a satellite transponder in my car to make sure if something happens, I can get help, and people that live there, we'd have to figure out some type of satellite solution, I think.
That's an excellent point. And I will say, even when I live in North Carolina, I don't have strong cell phone service to the point that I went to Verizon. I said, I'm paying you a lot of money each month for the list. And so they gave me an extender. But then it's almost like they just need to build some more towers, because they say if you're 5 miles or beyond where the closest tower is, it's going to impact your cell phone service. And I never realized that, because you don't see enough towers to think that most people are within a 5-mile radius.
I want to just acknowledge that Sharonda has her hand up, but I'll also just give you a personal anecdote. In New Hampshire, certainly broadband and cell service is an issue, but small towns do not want cell phone towers in the middle of their towns to take away from the charm or the beauty of the town itself. And so there's this, there's this tension locally that, yes, we want access, but we don't want this, this big sore thumb in the middle of our town. So I wonder if that's a similar story in other areas across the country.
A good point, Marie. Thank you. And yes, Sharonda, we see your hand. Thanks.
Hello. What I was going to say is that we also have to think about, I know there's a lot of programs for what's considered below poverty level with assistance to broadband, or internet access, or even hotspots or whatever. But we have to think about those families that fall in between. Not low enough to be considered poverty, but not high enough to get everything that they need. Some way we have to help those families as well. I know it's a struggle to be above that poverty line, but you're just right above it, and you're only right above it because of what you make before taxes. Not considering what they take away from you.
Yeah.
So you don't actually see that money that they're counting that's saying that you're above the poverty line. So there's a way that we can kind of incorporate something for them as well, just as a thought.
No, thank you, Sharonda. I think that kind of crosses all of the work we're doing, that we need to always remember kind of who our audience is, who we are actually working and focusing on. And let us not forget that population. Thank you. Okay, others.
And one last resource that I just remembered. So last November, FCC did have a joint roundtable with HHS on the intersection between maternal health and broadband data. Okay. I found the recording online, so I'll post that, but we can also see if there's been any follow-up since the roundtable. But it was to gather thought leaders on the front lines of the maternal health crisis, including telecommunications and public health, to explore the intersection of broadband connectivity and maternal health.
You send it out to the group.
That'll come via email. Good.
I'll put it in the chat, and then yeah, I
I'm
can.
not good at chat. Thanks.
Yes, sure.
And what I'm hearing is that is an unspoken assumption that the pregnant person is not homeless. And so when I think about those who are homeless, certainly we want to, housing first. And how do we engage with them electronically? And I wonder about the library system. And a lot of people do go to the library for internet access. And if there would be a recommendation for the medical system to engage with libraries for more reasons than that, but that would be I think a very compelling reason to support libraries to be able to have a private room to have a telemedicine visit, and then more access to Wi-Fi in the library for all sorts of reasons, that all the information that could be available.
Thank you, Sharon.
We had an initiative in Wyoming, I can't remember who funded it, but where we placed telehealth booths in libraries. Might have been USDA that funded it. I'll take a look to see if I can find what that was.
And Caroline, I don't know if you heard that or not, if you know if whether USDA may have been piloting something with libraries. Just if you've heard of something, let us know.
Sorry, I had not heard of that. I am happy to reach out and see if that is something I can get more information on before our next meeting for sure.
Thank you.
Can I add something?
Sure.
So you might want to look at the USDA distance telemedicine program. And actually that program is currently open, that funding opportunities for currently open. They have a website where they have the list of all the grantees and you can look for those kind of projects. And this will be the kind of projects that they will fund.
Thank you.
I'd be more than happy to send you that link.
To say I have that link. I'll drop that link in the chat too. Thank you for recommending that one as well.
We'll grab everything that's in the chat and get it back out. So I know not everybody's on. Marie put a note in there. Would be interesting to know if HIPAA compliant mechanisms for telehealth services. Okay. Good point. Thank you, Marie. Lots of information in the chat. Okay, so going back to preconception and interconception health. It does seem like there's many areas that's going to cross over into other areas from what you all are asking on preconception, interconception. I do want to go back to your question. Is there something missing that you all should be considering around preconception and interconception?
I have a thought on this, and I'm just channeling the respected Jacob Warren. You know, I've given some thought to measurements related to preconception health and interconception health, and there's not, I don't know, it seems like with all of what we put forward, it would be helpful if we, you know, had some data. And maybe if you presented that, Phyllis, and I didn't listen enough, forgive me for that, but if there was some sort of how we're measuring the effectiveness of what we're doing or not doing in that arena.
I think one thing we did talk about is are there existing surveillance systems, public health surveillance systems that capture that data?
Yeah.
So I think that absolutely is a big part.
Are there, aren't there, and yeah, what did Sarah knows a bit about this. She actually, Sarah Beese is on your group now, right? She wrote a paper on this a while ago, but the idea hasn't gotten traction from it.
I'm wondering if Title 10 would have anybody who could speak to this. Our Title 10 office is the one that does family planning and adolescent health.
Office of Population Affairs.
Yeah, so we can reach out to them to see if we can.
We had NIFR at one of the meetings. Don't know if we had OPA though.
Yeah.
Okay. We'll put them on the list.
Charlene, is there anything from DRH or RAMs that might, or other systems might be helpful?
Well, I do think PRAMS is intending to pilot collecting data in the postpartum period, later in the postpartum period than what they're doing now. So that is up and coming, but those data won't be available for a bit of time. But I can certainly get more specifics on that because we're interested in understanding experiences beyond that 4 to 6 months that they're sampling right now.
Yeah, it connects so closely to the 12-month extension that you were talking about. What are we capturing during that time period? What are the data elements? Do we even know if individuals are using the service? You know, we're given access, but what does that look like? And do people realize they have access? Anyone else? Have anything else that we feel like is missing? Yes, Jacob.
This is sort of anecdotal from my time
Mhm.
with our Healthy Start in Georgia. The problem we ran into with interconception care was birth spacing. And the issue we had with birth spacing initially was the gap in time with postpartum Medicaid extension to be able to have long-acting reversible contraceptives. But what we found was, we were very grateful for the clinical support we received through our Healthy Start grant. But we initially had a non-racially concordant provider. And once that person left and we had a racially concordant provider, our acceptance of LARC skyrocketed. And I don't know what we can be doing. Exactly. What can we be doing? Because for rural Black women, at least in the counties we worked in, that was just an absolute barrier. If it was not coming from someone they trusted, they were not going to get LARC for obvious historical reasons. And I don't know what we could be thinking about to help support LARC uptake or just similar items. I don't know what we could do, but it's.
This circles back to
Yes, Joy.
to workforce development and recruiting from within the community, providing education and opportunities to become healthcare workers.
But it also goes to the whole issue of coercion.
Yeah.
And that is what communities fear. It's the coercive nature when you try to elevate it to providers, making sure providers are not coercing, that they're still doing all methods and making sure that they're making a choice that's best for them.
Yeah,
Phyllis and then Maria.
yeah, I think that's what we talked about even in a broader sense is how do you do the messaging around this? Because people hear it as coercion and something negative. And And not only historically for African Americans, but just across all of the diverse populations. And so that has really been a challenge. And we've talked a little bit about that in terms of how do you message the message in a way that's, and I think also there's misinformation about methods that can be used when women are breastfeeding. And sometimes women are discouraged from breastfeeding because providers may have misinformation. And if you breastfeed, you can't use any contraception. And, you know, so I think messaging and education is, we'll continue to discuss, but that is an important issue in this area. I wanted to say too that on a different topic, but the kind of families that Sharonda was talking about are United Way has a category called the Alice family, and it's an acronym for Access Limited Resource Constraint Employed Individuals. So these are people who are employed but don't make enough money, as Sharonda said, to meet all of their needs. And so sometimes I think they fall out of the needs and services, just as families in poverty.
Thank you, Phyllis. And I've got Marie up, Marie, and then I'll get to Charlotte. So please remember to identify yourself before you speak. Remember, we've got others taking minutes and they won't always recognize our voices.
Thank you. This is Marie Ramos, committee member. I'm very happy that we were starting to talk about access to LARC, long-acting reverse contraception. There are a couple of things that I think may be helpful, and I'd be curious to know about the community psychology around, or cultural psychology around LARCs particularly. So there is an access issue because for many clinical providers, we have to buy the LARCs and we're not reimbursed for application of the LARCs. And so there's a disincentive from a clinician standpoint for things like the Mirena, the Skyla, and the newer generation LARCs. And then on the patient side, some communities, it is very normal for very young people to become pregnant, and it's part of their community and cultural norms. When I was providing maternity care in rural California, it was not uncommon for young ladies within high school age to become pregnant and to not go to higher level education, etc. And in some cultures that is part of their norm. And so how do we provide culturally appropriate education in a way that's trustworthy? Some communities, and particularly in the Black community, there is a concern of putting foreign objects inside of one's body. And seeing this procedure, although outpatient, as an invasive procedure. And then the last thing, as far as disincentives to getting these placements of LARCs, particularly, is the pain associated with it. And so it is not uncommon that women are not, or persons with services are not provided with appropriate anesthesia and pain control when this is being placed. And it is painful. And so there's this concept of, again, the dismissing of women's pain. It was discussed yesterday, and not really understanding or pre-medicating patients appropriately for these GYN procedures, albeit quick, albeit simple from a procedural standpoint. So it might be of interest to the group to have a better understanding from a sociologic standpoint, from a public health awareness standpoint. What are some of the disincentives, both on the patient side and within the clinical side, for providing these services? another caveat, just as a physician who provides these services, sometimes the actual procedure itself will be paid and reimbursed, but to acquire the long-acting reversible contraception is still a cost for the practice, and that's included for a federally qualified health center. So that's something to be considered as well, and might be a low-hanging fruit for recommendations. And I'm speaking a lot today, but I want to make sure that I'm getting this in because it's very important. The other consideration, we talked about political determinants of health in some states that are becoming very restrictive when it comes to interconception, women's bodily autonomy. They consider use of LARCs. There has been legislation where the use of LARCs is considered an abortion, thinking about termination and when does life begin. Does it start at conception, or does it start afterwards? And so the criminalization of even the process, depending on what state one lives in, may also be an inhibitor of access that we need to consider as well. So I think that's all I had as far as LARCs are concerned, but it's quite, it's a volatile space that we're living in right now from a health policy standpoint when it comes to bodily rights of the uterus. So.
Thank you, Marie, and we appreciate you talking a lot today. That's fine. But you brought up some excellent points though, and we probably need to think through is if there's OPA, is someone we can get to speak up. Also, there's a national group that's focused on pregnancy and tenderness, Upstream USA, so we may can, get someone from there. I'm familiar with them because we're one of the states that's partnering with them in North Carolina. But it may be another group that we can get to bring some of these issues to the table. But now I'm gonna turn it over to Charlene.
Thank you. Charlene Krollinger, CDC. I think I wanted to build on what Marie mentioned, actually, with in terms of patient-centered counseling that's provided in that suite. I think there also needs to be some examination or inclusion of LARC removal. That can sometimes be a barrier, and both for the patient and the provider. And some state policies actually have removal included, but some don't have that language. And so there may be questions or there may be concerns about placement if a patient will come back and ask for it to be removed. And then I think also reinsertion is another issue for consideration. I'll mention that CDC is updating its medical eligibility criteria and its selected practice recommendations, and that will be coming out soon. But just wanted to bring that to everyone's attention. And as Marie mentioned, we've examined the reimbursement for the device versus the provider practice expense. And there are some real discrepancies in what's available in certain states. So that might be something to examine as well. Thank you.
Thank you, Michael.
Two quick things. One, quickly building on what Charlene just said. So I just pulled up the Women's Preventive Services Guidelines. So, these were passed in the ACA, and things that are listed there have to be covered without cost sharing by most insurers. And specifically around contraception, when these were last updated, the initiative added contraceptive care also includes follow-up care, e.g. management, evaluation, and changes, including removal, continuation, and discontinuation of contraceptives. So there may be an educational opportunity to that point, both to consumers and payers, because we know these are not often well understood. The second thing is just to plant a seed. We often jump to Medicaid as a source of funding, and understandably so. There's also a tool that states have as part of their CHIP funding, so the Children's Health Insurance Program. There's something called Health Services Initiatives, where states can spend up to 10% of their CHIP funds on administration. And if there's a gap between what they actually spend on admin and that 10% cap, they can actually pay for a number of other population health service efforts. So some states use this, for example, for poison control, for school-based health services, for lead testing and abatement, for family planning services. Yeah, there's a gap. And I think there are some states that have figured that out and know how to do it, and some that don't. And it can be a decent sum of money for projects like this. So something for us to think about.
Thank you.
We'll send the link.
Great. Yes,
Yeah.
Steve, and then I'm gonna move us to the next question.
Oh, sure. Quick. Yeah, I'll do it quickly. Steve Calvin, committee member position. And piggybacking on what Marie said too, having the experience now of 4,000 births over a decade at a birth center, including many from the Somali community. They're that because of the concerns about, sort of foreign objects and things put into the system, there is actually a lot of interest in the fertility awareness kinds of things. And I know kind of reading, so as I've read about it, sometimes HHS and sometimes federal kind of guidance says they don't work very well. And I can tell for sure in training of residents, many OB/GYN residents are told that doesn't work. But what I would say is there is kind of a movement that's very much crosses ideological lines of a desire for that kind of information, or what some people call natural family planning, but the fertility awareness, and it's very impressive. Obviously, it takes collaboration of partners. And so that makes, sometimes that is a barrier. Anyway, I just wanted to throw that out there that we shouldn't forget about that.
Thank you, Steve. We're gonna go on, because I feel like we can continue the conversation, and we're moving it back to the work group a little bit. But in our rural health work group, you all had a couple of questions too. One was around the telemedicine model. Remind me your question again.
That we were looking for subject matter experts, so we got some good referrals.
That's some good ones
for that
yesterday.
piece.
And you also wanted representation from individuals with lived experience and how to include them into your work group.
Right, we got good feedback that we'll be able to, there'll be a mechanism actually to. Okay.
Yes, we're going to explore using the logistics contract, which currently has speaker, as you all know, speaker and presenter honorariums, and includes their travel. My question was, this is for all of the work groups, in terms of timing. I mean, I don't envision that we could pay for monthly call participation, but potentially if, the next time we gather in person in June or the fall meeting, if you feel like there's a stage in your recommendations development that would make the most sense, to bring in, people with lived experience to review, or,
Can we explore the monthly participation? Because the purpose of bringing in individuals with lived experience is to have them equal at the table. And if we only bring them in once a quarter, that is not us doing that. And I know it's not, it's a system. I deal with this system in my own state. And we've been able to get through it, but it takes time. But I don't want us to go down the road of saying we can't do it monthly. I think we need to figure out how we can do it monthly. If that's the purpose of having individuals with lived experience in a work group. And it may be even finding out if you identify a couple of people for your work group, they may not want to do it monthly. They may say, I don't have that capacity, I don't have the time. But if they say yes, I would really hate to say to them, but we can't cover your time but once a quarter.
Can I pose a couple questions to you, since I'm the person who's going to have to argue this for the budget?
I could give you some thoughts of how we've done it in my state.
I think we're supportive of the idea and the approach. One of the sensitivities that I have is that because it's a FACA, we have worked very hard to have these work groups not have to go through some sort of a clearance process for who might want to participate on these, because the FACA rules are very, very stringent when it comes to how we select who gets on who gets to weigh in on this. And so the idea would be, how do we put something like this in place? And if we're looking at paying them so that it looks like we've got some sort of a process to make sure that we are representative, or not to raise any red flags. I don't want to create a process where we're getting outside input, but the person who's going to give us outside input has to go through some sort of a review. And so that's what we're trying to balance here as well. We're all supportive of compensating people, and I can work to make those resources available. And this is a good time because we're in the process of putting together what our plan is for the future contract for the logistics activities.
But those are some of the concerns that we have.
No, thank you for.
Charlene's nodding.
Well, and again,
More complicated than I would have ever thought, but yeah.
And I apologize if you thought I was saying you weren't supportive, because I believe you all are supportive. I'm just trying to think, I want to push us to figure out how to do it. So that so it can be done versus to say, these are the barriers. So how do we go beyond the barriers so that we can get it done? I think it's.
And we'll think creatively.
May I offer a suggestion?
Of course. Yes, Marie.
Thanks, team. And could a possibility be that we need more than one community member on the committee, period, right? If we're asking folks to join our subcommittees, then what I'm hearing is that there might be a broader need for particular subject matter experts of particular experiences within the community that are part of this overall committee itself, that could lend to the enrichment of the work.
No, I think you're on point, Marie, and I think, we all rely on Sharonda for many aspects of our work. And I think all of us around this table, including our federal partners, would say we need more Sharondas.
That may be a way to check all the boxes.
Yeah, we also.
Won't that take long?
But it will take us,
Gave us that recommendation in 2020 and we have actively.
And we submitted that nomination shortly thereafter, and
Yeah.
we're still waiting.
Yeah.
that's what I'm saying, that can't be our only way.
Mhm.
No.
Understood, thank you.
And we're on a timeline now, right, where,
Yeah.
if we're trying to be
Your name.
sorry.
Who are you?
In blue. I'm a committee member. We're on a timeline now where Linda's asked us to prepare recommendations for January. So we were thinking that by, 3 or 4 months from now, we're going to get into the writing, and the recommendations. So the input needs to be now. If we're going to be genuine in this. So, if we need a fallback, Jacob and I talked last night about, panel groups, that sort of thing, that we could turn around fast without full committee membership. That might be, we just need to know what we need to do, in terms of.
I think if you could identify one or two for June that we could travel in, they could stay, listen, they could speak perhaps, but then also sit in on your work group time and be actively working with you during the meeting. We have the speaker on RAMs right now.
If the plan is meetings of work group, we're really working work group meetings during our June meeting. I'm sorry, say it again. Then I think that might be a feasible way to do it, because you'll be compensating them at that time. So Jacob, I don't want to speak for him, but that.
Their travel.
No, I don't think June will be an issue if work group members, if you've got individuals that you want identified, they've come to you and say they want to be on your work group. Because I know one of the young ladies yesterday was interested in joining the preconception and a conception work group. I don't think June is an issue. I think it's the other meetings outside of June. It's trying to figure out how to cover and compensate individuals for their time there, just like we are all compensated. So I think that's where the issue is. Sherry.
And this is Sherry Alderman, a committee member, as we go down this path, which I think is a really important path and can carry a lot of meaning. And considering budget, we also would want to consider budgeting for simultaneous interpretation for a person with lived experience that does not, that has a preferred language other than English.
Thank you.
Linda, I don't mean to put you on the spot, but do you recall how the last set of recommendations with AIN, some of the, techniques you guys used then? I mean, I didn't participate as much in the work groups at that time. I know the tribal meeting gave the ability for many to put eyes on the draft, but at that point they were already drafted, but it was time to give reactions.
I think that's a great point, and I don't think we did our best job with engaging individuals with lived experience in all of the work groups. Janelle and I were doing the health equity one, and, we would get feedback, by people that came to the meeting, but I'm not sure we could clearly say we identified individuals with lived experience or community members to join the work groups. I think what we relied on is individuals that work with individuals and they represented them versus the actual individuals with lived experience.
Okay.
And I don't think, I don't know if Ed or Magda or Janelle, any of them are in the meeting, and they can drop it in the chat, but I also don't recall it for the data group. I don't recall it for any of the groups that we actually made it a concerted effort. I think we were getting feedback at the meeting in Minnesota, and that's when we were able to listen, and that's where we pulled in the recommendations. I think this iteration of ACIMM, we're basically saying we want to go a step beyond that
And then
and actually bring people in with lived experience to join the work groups. And we just need to figure out how we can get it done, realizing we don't have much time with these recommendations.
And Ed is in the panel or attendee side. Ed, if you do have anything to add, I know you can't chat it, but if you want to raise your hand, we can. If there's anything you want to add, okay.
Yeah. Okay. I think as work group leads, if you all have identified, one or two individuals with lived experience that you want them to join your work group, then, reach out and make sure we know, we're trying to figure out what the process will be. And again, June is a definite, that should not be a problem, because we can bring them in as a speaker. At the June meeting. Okay. Going back to the rural work group, any other questions that you all want the larger group to discuss?
The only one we had is the same with interconception. Was there anything missing?
Anything
From
missing?
y'all's perspectives?
And Steve Calvin again, and what Kate mentioned too about this, it's kind of a unique idea about emergency departments alongside birth centers. I mean, we've engaged with Jennifer Vanderland from ACIMM, the midwifery organization, and Julie Wood from family medicine. I mean, the rural health maternity care situation is a real crisis, and we have to maybe test a few things. I know there'll be people saying, oh no, you can't do that. You can't have births unless you can do an immediate cesarean with an OB doctor. But I think we need to push the envelope a little bit, not for everybody in every location, but we should figure out a way to try it and engage the emergency department, the emergency physicians, the surgeon in town to say, is this something you'd like to do? And then the community, the midwives and those in the community that are just saying, hey, because there's such, I mean, in Minnesota, it's happened 4 or 5 times just in the last few years. A community hospital just shuts it down, and then they're mad at the healthcare organization who then say, well, we can't afford it. We can't afford to have the coverage. I don't know how to go forward with that, but maybe by June we could come up with here's a scenario, here's what we should try, and then make it very specific.
And I think, Kate, remind me, in North Carolina, one of our hospitals, when they were getting ready to close, they switched to only family medicine doctors. I remember Chatham.
Chatham system very well.
Mhm.
It's just an hour south of UNC, and they, we back them up. They
It was in front of something
they
different.
did close their maternity unit. And then years ago, and then opened it again with the family medicine led
Team.
team.
Mhm.
And the family medicine providers, had cesarean, could do a cesarean birth, and but the number of births was infrequent. So those family medicine physicians come up to our unit and operate once in a while, and we incorporate them into that's a, and
Let's
it,
try something different.
yeah, and I mean, there isn't a whole evaluation of that program, and there's a lot of bumps, and with Jeff Strickler, no, he knows a lot about that. Who spoke to us at one point.
Is the administrator?
Yes, he's an administrator, but we also, there's a family medicine physician that led it, Martha, I think her name, but but it was done with funding, and really under it by the health system. But it was done for, there's an educational grant too, because the idea is we have a family medicine program, training program, and they wanted their family medicine residents to experience practicing maternity care in a rural area led by family medicine physicians. So there's a lot of evaluation pieces built into that. But it's not a birth center. I mean, they have an operating room and they have GYN surgeons down there and all that. So it's very different than what
we're talking about.
what Steve's suggesting. You know, I could go on and on, but I think that there's that we could design something with enough measurement safeguards in it and that sort of thing that could be a potentially, you know, funded private, you know, but it's tricky.
Okay.
And this is Sherry Alderman, committee member. I'm hearing also another aspect of isolation that impacts health, and that is the providers. And I love hearing the model that's going on in North Carolina, where the physicians are practicing in a rural area and have that really meaningful connection with a more a hub that can be also shared learning.
This is Joanne Einhart. I wonder about keeping providers, keeping up skills, because, you know, in a small hospital where there's only a C-section every other month or so, that's not going to be enough. And I know that in my small hospital in Juneau, Alaska, you have to have X number to maintain your credentials for that procedure. So what about having people who are from larger institutions rotate through on like a weekly or 2 weekly basis, so that if the procedure is needed during that time, it gets done by someone who practices in a larger area and has that skill and continues to use it all the time and brings it with them, rather than trying to keep people in this community up to date, because it doesn't seem possible if the numbers are small, yet you want to maintain the high quality of care. So that's a thought.
Yeah, and Belinda, this is something that Jim is,
Kate
Kate Menard again, but Belinda knows our region, but our northern eastern aspect of North Carolina has a lot of very rural counties and infrequent
Right.
births and that sort of thing. And we have a very dynamic leader in that his name is Jim Devaney, and he's now thinking about, and their quaternary care center is supportive of getting out. You know, he did a lot of outreach, a lot of simulations in these smaller hospitals, but now actually taking providers out there on a rotating basis is something he's thinking about and planning. Well, I don't know if you knew that, but there's those ideas, but it hasn't been tested, you know.
It's Michael.
Michael Warren, this is sort of conversation is making me think about the HRSA Teaching Health Center GME model, where within the community health centers, there's been additional funding for GME for folks to train, so to provide faculty support for training, but also practice. You're getting the training and the clinical service at the same time. And I wonder if it's not, I realize it's not just having a person issue, there are other issues, but I wonder if there are some variations of that model too, that might help with some of the recruitment and retention piece. And to get to what Joy said, just we could pull in the right folks from HRSA to talk about like what that model is and how it's been used. But I wonder if there's a variation of that might work.
I think that would be helpful to hear someone from that perspective to talk about the program. We can get someone.
So what group would that be?
Yeah, Bureau of Health Workforce, between them and our Bureau of Primary Health Care, between the two of them at HRSA.
We just need to figure out if that's something everyone wants to hear, or if for just a specific work group is interested in this area. Okay. Wonderful. Okay. So anything else we think the rural health group is missing? And I think Ed, you've been moved up, and Ed Ellinger. I don't know if you have anything you want to add in about how we've engaged individuals with lived experience.
Good morning, everyone. It's really good to see you there. I have to compliment you on this meeting and the work that went into making this happen, and Sharonda and the staff of HRSA and CHB, that it sounds like you really did all of the real good legwork of making this a meaningful meeting. So congratulations. And I have been, stalking the meeting, and it's been run really well. Belinda, you're doing a great job. So relative to the question of input, this is always one that is difficult. We tried to get as many, as you remember, tried to get as many people to come to the meetings and testify as best they could. And that was the reason we brought them to Shakopee. But in between meetings, both Janelle and I worked a lot with community-based organizations to get their input on the recommendations prior to the recommendations being drafted. So it was, again, working with community-based organizations and the connections that they have with the people that they serve, as opposed to bringing those people to the committees to work. Because as Lee pointed out, there's some difficulty with that, and there's some, it's a logistic kind of challenge. But whatever we can do to get those voices is a good thing.
Thank you so much, Ed, and it's great to see you on screen. Thanks. Okay, so we're going to now switch over to the social determinants of health work group. I know one of your areas that you wanted to talk a little bit more was around how the issue of isolation connected with the other work groups, not just looking at it as a social determinants of health area, but how it connected to the work of the other work groups.
Just to note, Marie has stepped away.
Marie has stepped away. Okay, thank you.
This is Sherry at Alderman. We're very interested in the loneliness and isolation as a social driver of health. We're also very interested in all the other aspects of what we're looking at in terms of social drivers of health. And I hear that the overlap with the other groups, and so I'm curious about what could we do to continue to explore those overlapping areas and coalesce our recommendations, given that we are going to be committed to having fewer recommendations than we did previously. So and the timing of that, what would be the best timing for the group to begin to that process.
Any thoughts, anyone?
I would think probably by September and December meetings. I think work groups are still gathering information, trying to figure out how to do it. I think that the cross-cutting edges issues are gonna emerge once each group presents what they're thinking in terms of recommendations. And I was only on the end of the process for the AIAN recommendations, and it seemed to me that was the process that each subgroup presented, and then they were massaged several times. We looked at them in condensed. People won't believe it, but it was condensed some. And I think also it will have to do with how we frame the preamble or the introduction to the recommendations about what's going on. So I think right now, I think we should just continue to be broad and gather and think and trust that it's going to come together. I'm sorry, I'm Phyllis.
Thank you, Phyllis. Yes, Kate?
I'll just add to that, Phyllis. I agree with that approach. At the same time, I see that some themes have emerged. I think this broadband discussion was a good one because that cross-cutting. I think that, and it's not just rural, it's urban. It's certainly cross-cutting. The other cross-cutting theme that's coming through loud and clear to me this week is the need for, the most effective, what are the most effective and cost-effective ways to deliver information in ways that people can receive it. And that's cross-cutting, so if we can identify cross-cutting things now that we know that we can all of us need to learn about, every single person, every work group, then we can do that potentially all together and not put it on our specific work group list. And the broadband conversation was certainly on our work list. Now it's on the whole groups, right? So I think that's going to come through really importantly in our report. And so I thought
I think the other thing,
Name,
Phyllis, committee member,
they're texting, they're sending me notes in the chat. They need to know who we are.
Phyllis, committee member.
Thank you.
I think the other thing that has emerged, that's an underlying thing that is the harder issue to address, and I think it came through on the tour. I think it came through a lot in the community voices and some of the programs, is the whole issue around systematic racism. And it, it impacts everything that we do, but and this whole notion of political determinants of health, that was a new term for me to think about. But in as much as we can address those, which will come across in how information is delivered, how things are communicated. But if there are system things that are also getting in the way of rural health and, contraception care and social determinants, whatever way that we can do it. And, and I know that HRSA is a part of the government, it's their political stuff, all that kind of thing, but we have to address that too. There has to be multiple, it's not only just individuals and individual projects. We do that very well, but what we need to also start paying attention to some of the system issues that we can tackle within the purview of the power and whatever. Because as one of the members of the community voices said, we're just gonna, we're like a rat in a maze. It's just, we just keep going around. Some issues will improve for a cycle and then they won't,
Thank you, Phyllis. This is Belinda talking. And I think you worded that very nicely. I do appreciate you.
Not offensive.
You did. But I think, one of the reasons we keep saying we came to St. Louis was to listen. And then pretty much the vast majority of the presentations that we've heard, especially yesterday from the community, they brought up systems issues. Whether it was, around racism, whether it was systems issues around other areas, but they keep bringing it up. And I think and then we had our HRSA administrator tell us to be bold, to think outside of the box and really look at our recommendations from the standpoint. It may not be something that can happen immediately, but it is something that we want to say as a committee that we are elevating and it is important. And we have sent that forward so that others know that it is important. So I appreciate you wording it so nicely, and we'll have that for the minutes so that we can come back to it. But I do think all of us in the work we're doing in the work group and as we're coming through the recommendations, we need to think boldly. We do need to think outside of the box. We need to think about what do we really think could move this work forward and we can see improvements. Maybe not immediately, but we should be able to see improvements in the future. Because it takes quite a bit of time, as we all know. Yes, Kate.
Sorry if this is Kate Menard. Sorry. Yesterday when we were listening to the panel, what came loud and clear, that came through from every speaker that racism needs to be addressed. So my question to the group is, who's really got it? And so there was, well, what do we do about it in terms of, my heart just says, so what do we do? Yeah, I don't have an answer to that. But what if we need to put who does what when, right, into our recommendation sort of thing? And where does that fall in the work? Is that a big agenda on the SDOH work group to kind of tackle that? doesn't really quite fit in deep dive into the rural. I think there's bigger, not bigger, different issues there. So I guess I need to know, kind of think if we're going to do that, we need to include that, right, as an overarching goal, but where's it sitting?
Yes, Sherry.
This is Sherry Alderman. Yes, I think so. And that's something that we are moving in the direction of, I believe, and I definitely invite Maria to chime in when she's back on this. And that is that, and I'm repeating myself from yesterday, it's if we don't address the political determinants of health, one of which is all of the social constructs and legislation, et cetera, that contributes to a racist system. We're just to put it bluntly, we're spitting in the wind with our recommendations, because what will prevail, and this is evidenced by history, what will prevail are the political determinants of health after we submit our recommendations at a pinpoint level. So I really welcome learning more about it myself, and how we can, and exploring how we can make recommendations that at least put a crack in the political determinants of health and consider that. So I'll stop there.
Yes, Joe.
And to expand, this is Joy Nehart, committee member, and to expand on what Keith and Sherry began, what, the foundations are going to be to break down what and structural barriers are. Bringing food, so grocery stores, bringing transportation, so public transport, and bringing healthcare back to where it was taken away and where it isn't right now. This is what we learned on the tour yesterday. This is the foundation. So we can, again, recommend programs, but the programs aren't going to go anywhere. It's going to be that spinning wheel until the foundations are brought back.
Thank you, Joe. Yes, Dave.
Yep, Steve Calvin, committee member. What I was most struck by too, I mean, a lot of what we heard, is uncomfortable here. I'd say a caution too, before we get too far into political determinants of health, we have to remember that it's a deeply divided country. We try to find out what is it that actually unites us. And so I would say the thing that was most powerful to me was hearing Okonsola, the founder of the Birth Village. She pointed out, she went past things and she said, we need risk appropriate care. And I think if there could be, 700 of, Okonsolas in the country, that would make a huge difference, because she gets it. She gets stuff that crosses all kinds of political divides. Will say, we need the kind of care that is appropriate for low-risk mothers. I think she pointed out that she said 90%, and that might be a little high, but the vast majority of pregnant women are low risk. And so it's that kind of thing. We need to find those kernels and say, that's something that I don't think anybody can argue with on a political sense or ideologically. They can just say. So, I'm not opposed to description of political determinants of health, but here you're in Missouri, where it's the flip opposite of where we are in Minnesota, where there's a majority that are doing things that make a lot of us uncomfortable, sad. But so we're going to have to figure out ways to navigate that in a prudent way.
Thank you. I'm gonna get to Sharonda because her hand's been up a minute, and then Sherry.
And one thing I do want to recall from yesterday is that it's not just a social determinant of health or political determinant of health. One thing that panel did bring up is that in order for us to be healthy during preconception, that systemic racism has to be addressed even before the pregnancy. So it's an reaching, it goes into all of our, basically, to all of our work groups is something that touches every last one of them.
Thank you, Sharonda. Jerry?
This is Sherry. Again, I agree with everything that's been said, and we do have to be very thoughtful about how we present our recommendations, given the current climate, to have any effect at all. So I totally agree with that. I also, I'm thinking about what Joy said, and that is that there were things in place and then it eroded or evaporated. And I wonder, I'm curious, why did that happen? And where I go with that is that it was the political determinants of health that prevailed. And so we can have, the US culture seems to be, my perception is that the US culture seems to be very effective at responding to urgent needs or catastrophes or some really compelling circumstance that warrants a social response to address. And then when that floats by and passes, we go back to business as usual, and those are the insidious presence of political determinants of health. And if we could really make a significant shift in a way that really captures what we all share, the values that we all share across the board, that I think that we can then shift the political determinants of health to be positive ways of addressing health and well-being for families and mothers and babies.
Thank you, Sharon. And Phyllis is going to be our last one. So we can try to get back on schedule a little bit.
So, we certainly may not be able to change the world with one report, but I do think what was really great about the Indian Task Force Native, was the large introduction preamble that kind of gave us the context and the history of the disparities. And so maybe we can start our documents that way, at least put it out. And this, because of these contexts, this is what we're looking at now, and these are recommendations, that we think that will help move the health in a more positive direction. In the end, it's always about power and control, and so.
Thank you. And thanks to everyone for all of your feedback. This has been really good conversation around the work groups. I hope it was helpful, especially to each of the work group co-leads as you move into the next level. Yeah, we will already, I've already started thinking some in my head about how we do the introduction to our recommendations as we are focused on improving Black maternal and health. So any thoughts that the rest of you all have, I think we definitely would appreciate receiving them. So thanks, everyone. Okay, anything else around a work group at this point in time? No thoughts? I'm going to take us back then, because we skipped over it, just to make sure we had some of Marie's time, and go back to our area around the recommendations from our former ones, our making amends recommendations. And really want to see if there's any updates from any work that any of the committee members are doing. I don't know if Vanessa, if you've got anything you want to share from any of the ex officios, you or Sarah, from work that's going on around working with American Indians, Alaska Native, to move those recommendations forward. I know Ed is still in the meeting. So we will take a few moments now to get any updates there.
Yeah, happy to give some updates. Sarah Meyerholz, the ACIMM program lead. My other half of my job is the program lead for state maternal health innovation. So our updates today will primarily focus around what those grantees are doing. And just to give you like a quick high-level overview of what State MHI does, We currently have 35 states with this funding, and it includes entities such as public health departments, universities, hospital systems, and we do have one community-based organization, and their goal is to improve maternal health by establishing a statewide maternal health task force, improving the collection and use of their state-level data on maternal mortality and severe maternal morbidity, and then launching innovative activities, which can fall under health service delivery, enhancing data capacity in other ways, and health disparities. So happy to provide more information about the program overall at any point in time. But I did want to provide just some specific AIAN updates. On March 13th, the Maternal Health Learning and Innovation Center, MHLIC, who's the TA provider for this portfolio, they launched a community of practice for any of the state MHI awardees who are interested in authentically engaging Indigenous populations. So looking forward to seeing where that goes. I have a lot of updates to read, so I'm very sorry. But this is all for the notes. We'll have it on the transcript. So as you all know, there were 59 recommendations. I'm going to speak to 3 of them today. AIAN 1D, which talks about consultation and partnership with AIAN elders and others with relevant lived experience. Just paraphrasing that. We do have 2 awardees, both in Arizona and Montana, who are partnering and creating tribal maternal health task forces. And I will include in the chat, there's a link to a tribal specific maternal health strategic plan. Yes, from the Arizona team. The Montana team actually sits within Title V, and they co-host 4 healthcare immersion days a year with reservation communities. And these immersion days build off of learning and experience of life blessing immersion days that took place in Blackfeet Nation in August 2023. And these events bring together provider teams from Montana's participating PQC hospitals and other program staff in selected tribal nations. So it's an opportunity to build relationships, gain familiarity, and generate multiple compassion and cultural exchange. You have that, can you put it in the chat? Thank you. The next recommendation, number 11, talks about strengthening accountability for how Title V resources are employed within, by, and for tribal communities. Going back to Montana, which does again sit within Title V, they're currently working with powwow committees to identify opportunities to sponsor dances and serve as an exhibitor to create a positive presence within tribal nations and other Indigenous cultural events. And this allows them to connect with Indigenous populations as they start to think about how to complete their Title V needs assessment. So those are every 5 years. The next one is coming up in 2025. And then the last one is number 26, which is investing in training of AIAN doulas and traditional birth workers. And we're actually moving to Washington State. So the Washington State Maternal Health Innovation Program has a doula Medicaid benefit that's been proposed to the legislature. And in preparation for this new benefit, the Washington State MHI program has partnered with Doulas for All to develop community education and awareness in tribal communities on what a doula is, how BIPOC communities can access doula care, and workforce pathways into doula careers. In addition to this, the state also launched doula certification in 2023, which will be a requirement for Medicaid billing. The state MHI staff in Washington are also currently collaborating with certification staff to ensure that their funded birth equity partners, which do include 2 tribal doula organizations, have support in applying for certification. It's a lot of information, but our state MHI portfolio, like I said, is doing a ton of work, not just in AIAN. So if there is ever interest in learning about some best practices that we know are coming out of this portfolio, happy to share them at any time. Vanessa, I'll pass it to you.
Thank you. I have updates from Dr. Tina Patara Lau from Indian Health Service. She unfortunately couldn't be here. She's on annual leave today, but did send us some updates she wanted shared with the committee. The Indian Health Service Maternal and Child Health Program is still continuing to work on initiatives to expand access to safe, quality maternity care in the community and reduce maternal and newborn morbidity and mortality. So they're leading with cultural safety, which means creating programs by and for the people they serve. And they are being intentional about lifting up Indigenous leaders in their work. And some of the examples she shared, they fund the maternity care coordinators at federal sites to increase access to screening, education, and intervention through telehealth and home visiting during pregnancy and postpartum. There will be a partnership with trusted community leaders to extend care beyond the clinic and close the gap between delivery and the critical postpartum period. They will award $6 million to 6 sites in April of this year. They're also leading the obstetric readiness in the emergency department OB-RED program to provide sites in maternity care deserts, out obstetric services, and with tools and resources to safely triage, stabilize, and transfer pregnant persons and newborns. Over 24 IHS sites have reviewed the manual, 5 sites and over 225 staff have participated in hands-on simulation training. And they're currently working to provide technical assistance and training to 3 additional areas in 2024. Did I mispronounce this? Bemidji, thank you. Billings and Navajo. And last, they provide virtual on-demand education and clinical consultation to the field through Indian Country Echo Care and Access for Pregnant People. We can put that this link in the chat too, which is a series that's been attended by over 1,400 participants across all 12 IHS areas. Prior topics have included Indigenous birthing practices, Indigenous midwifery and doula care in Alaska, and urban Indian substance use treatment centers. The last webinar was recorded on March 26th, and it's available on demand. It's STI screening in pregnancy, how to use field testing and treatment for syphilis. And it was featuring the Navajo area, PHNs, and the CDC. So we can also put these in the chat. Those are the updates from IHS.
Thank you. Great updates. Sounds like at some point we may need a presentation on the MHI program.
Totally. And we continue as federal ex officios and agencies under HHS to meet quarterly. So in between our full committee meetings or aligned with the full committee meetings, we gather to discuss the AIA and recommendations. Charlene is often there as well as all of the folks online. Because this continues to be on our radar, we continue to check in with each other about what progress is being made across the department.
Can I offer a suggestion on that? This is Lee Wilson. I'm with HRSA. We are maintaining a calendar of the various programs that are within the division. And because we've been making so many awards, we've had a lot of kickoff meetings. Some of our programs have like an annual meeting. Kate has been involved in some of the MHI ones, I think, that we've been doing. But I don't know that all of you are aware of those meetings, and they're generally intended as technical assistance or learning institutes for our grantees on the program specifics, but then also on sort of models or topics that might be useful for their success. Most of those meetings are public, and I think it might be worthwhile for us to sort of provide to you on a regular basis an update of that calendar if you should choose to sign in, listen in at your interest.
Thank you. I think that would be helpful for everyone to know. And I was able to go to the state MHI one this year. Normally I don't make it there, but I was there this year.
Did you have fun?
I did. It was a good
Did
meeting.
you learn a lot?
Learned some things. I've been doing it a long time.
That's not the right hand. That's not the right hand.
Yes, I learned a whole lot, yes. Better.
I sat in, this Kate, I sat in on the reviews. I wasn't able to go this time, but I sat in on the summary, that was provided, and there was, I think people that aren't as wise as Belinda learned a ton.
Well, Sarah had a big hand in the planning of that one as well. So you know that, and Vanessa's very involved as well. So you know it went off extraordinary.
And I actually sat in on the session around the Learning Collaborative around American Indian Alaska Native. So you and I went in together. So yes. So we're excited to see the next steps on that one. Wonderful. Okay. I don't want to cut anyone off. Do we have any ex officio members that want to report anything they're doing around indigenous populations? Sarah and Vanessa did an awesome job pulling everything together. Yes, George.
Just a quick comment. This is Joy, an iHeart committee member. Thank you for that report because now I feel, well, I mean, it's very encouraging to see that all the hard work that came out of the recommendation compilation is being put into action. So thank you.
And it gives you something out, this is Belinda, it gives you something also to go back to when you're doing planning in your own states and your own community, things that you can work on. So it's almost like it's a blueprint in and of itself. Wonderful. Yes, Charlotte.
Charlene Crollinger, CDC. I just wanted to emphasize and thank the MCHB leaders for this committee, and the quarterly ex officio meetings are useful, and continue to spread your message among the different agencies in the department. So you all are being heard.
So now we can take a 10-minute break just to get us back on schedule. I want us to come back, do next steps and assignments and start and talk about the June meeting, because I know some of you are going to need to leave in a little bit. So we'll just take maybe more like if we could come back at 10:45, that would be great. Hello, everyone. We are back. This is Belinda. We're going to move on with our agenda back to, at this point, we're at next steps and assignments. And part of our conversation around next steps and assignments is really trying to think through kind of what our timeline is to get our recommendations ready. So as you know, we have a meeting planned for June. We'll be meeting in Rockville, Maryland, June 26th and 27th, and we'll talk a little bit more about that in a few minutes. And then we'll likely meet in September and probably December timeframe. That will get our time. I guess probably, because we have not discussed that, but we normally try to, if we're meeting 4 times a year, that will put us pretty much there. So it's really thinking through a timeline for the work groups to start thinking through your recommendations. So if we look at June, September meetings, we really need to have the recommendations, at least strong drafts of the recommendations by the end of the year, which would kind of put us in line with maybe having a December meeting. And this will give us time to have drafts, and that would still give us time to gather some feedback from some community partners, from some of the other national organizations that we pulled to the table initially to share with us what they were doing in this area, with the goal of having our recommendations final into the secretary February-ish, no, March. This will be done before my birthday rolls in March, so that's what we're going to go with. So sometime in February. So any thoughts about that timeline, any concerns about the timeline? We will use a June meeting. We will be in person, so we will use time for the work groups to actually meet in person, or it will still be hybrid for those work group members who are not able to attend the meeting in person. Then again, we would meet another time, probably in September timeframe. We'll just have to look at the calendar because we haven't gone that far. But we're going to look at that scheduling. As I'm looking at Sarah and Vanessa, thinking, ooh,
We have in the contract, I think it was October-ish.
October-ish, okay.
We know November starts to get hard with the holidays. September sometimes is just a bit too early because we award the new contract in August. So we want that contractor to just a minute to get up to speed before they're planning, because I think the meeting is scheduled for in-person actually.
The September,
The fall one is another in-person opportunity.
can we do 2 is the question.
They're 2 different contracts, so starting fresh.
Right, can we do 2 fall meetings?
Oh, was the question.
Mhm.
If one is virtual and one is in person. Well, we'll figure it out,
Yeah.
back to it. So don't put it on your calendar yet. Till you start hearing some dates, but I do think it will give us an opportunity to, spend some time, focus time on it outside of your work groups. But I think at this point, the biggest focus is on the work groups. So again, if we go with a time frame of having the recommendations in good draft format by the end of the year, with the goal of using maybe January to get feedback from partners and others at the beginning of 2025, so that we can have a final version of the recommendations February, no later than early March. Does that work for individuals?
Will there be new members coming? Because I think I'm the only one gone after December. Are we still?
We probably should talk about the timing of our committee right now, because I know we're all waiting for some additional members to come. And we know it's a lot more members, yes, we are. But we probably aren't gonna get a lot more, but I don't know. Vanessa, can you give an update on where we are with appointments?
Sure. We have 6 nominees under review. That's the group or that package. We've been hoping any day now by, each committee meeting, we say by the next one, we hope so. That is still our hope. I do want to be clear that package is from the solicitation we did in 2021. So there's folks, I think, who've been listening over the 3 days who may have been nominated as part of the solicitation we did last year in 2023. So that is another package that we are formulating and will be submitting for review as well. But just to be clear, the group we're waiting on that is currently under review came from the solicitation we did a few years ago. So realistically, we expect them to be brought on hopefully soon. And then we would have another package that's going to be under review from the 2023 solicitation. I'm not sure how realistic it is to assume they'd get appointed in 2024. If it was, it'd be, later in the calendar year or 2025. So I think, again, people who've been listening in who were part of this most recent solicitation and got nominated, we were hopeful and hoping that it would be a 2024 appointment, but we're just not sure given we're still waiting on this package downtown that's under review first.
Yes, Joy.
One quick question.
Joy. Name.
Oh, Joy Nyhart, sorry, committee member. One quick question is, the 6 that are under review, are any of them community members?
We cannot discuss
Okay.
the representation of the committee that has been nominated. And just for your information, the length of time that has passed has meant that there has been certain individuals who may have been quite interested, and 2 years later, they may have moved on.
Right.
So I can assure you, though, that all of the recommendations that had been made by the committee were attempted to be addressed. We cannot guarantee who makes it through the process.
Great, thank you.
We heard loud and clear the priority for community consumers. We're missing now without Janelle Palacios, American Indian Alaska Native representation. Minorities in general. So yeah, we are definitely heard the feedback and tried to incorporate that as we go through all the nominations that get received.
And does everyone know when your term expires?
Yeah, and I have that if you don't.
You do?
Jacob Warren, committee member. That's what I wanted to bring up because there were, as of March, which is our deadline for these recommendations, there are only 2 of us left. Everyone's going to rotate off in March, by March, except for 2 of us. So like that deadline for us is super.
That list you can.
So, Steve, as you mentioned, your term end date is December 31st of this year. All but Belinda, Joy, and Marie, the term end date is March 13th or 15th of 2025.
Okay.
Yeah. So February, March, we need to be thinking January, February.
I have to back things up a little bit. Though it seems like last go round, there was, I'm sorry, Michael, I will get you there. Were there extensions?
We did have extensions so that everyone could make it through the tribal meeting. We're going to be in person to finalize. And then Ed, his term ended in December and he submitted, literally like weeks before his term end date. And we can help facilitate that, obviously. So if you still want to move for early, like March 1st at the latest, we help you submit that to the secretary. And everyone's March 15th.
Okay.
This is Michael Warren. So we'll continue to nudge. We nudge, as Vanessa said, on a weekly basis, but the decision is not in HRSA anymore. It's going through that process. I will couch this in a very neutral, apolitical way. Is public knowledge there's an election in November. If there is an administration change, and this is true with any administration change, so this is not unique to this upcoming election. Processes around things like getting advisory committee members appointed, even routine business, there is often a delay at the beginning of any, reiterate, any new administration. And so I think as we're thinking about things like extensions, just need to keep that in mind, that things in a non-election year might be fast and easy or easier, are not typically in those. So we just need, and we can think with Lee and Vanessa about just timing there.
And historically, I'm sorry, Lee Wilson. Historically, when there is a party change, the rule is that there will be a halt on committees and committee nominations, changes, all of that, because there tend to be the incoming group wants to ensure that there is fair representation and thorough, and they do the vetting they would do. So food for thought.
Okay, so in reality, we need the 6 people to get appointed. Yeah, that's what we focus on. Well, we don't all focus on it, but we know you all have done everything you can to try to get the 6, because in reality, we could end up with, like we said, 2 members. And then we don't really know sitting here today who the secretary will be. But I think unless you all tell me that you have different thoughts, it would make sense for our recommendations to go to whoever the new secretary is going to be, because we want it to move forward, or we can back everything up and go with the current secretary, but we don't know who the secretary will be after the elections. It could be the same one, it could be a different one. So that's the challenge with, coming out with recommendations in an election year. So my thought process was to whoever the secretary is going to be starting in 2025 is where the recommendations would go, because they would have time to review them, decide how they want to handle them, but they will be coming from this committee. But others of you may have different thoughts. So if you do, feel free to share them. Take it that you all are in agreement then, otherwise.
Belinda, Kate, I just have one
Yes,
question,
Kate.
another naive question, but the name Kate Menard, there are exceptions for reappointment. Is that easier than extensions or no?
We're good. All right, so then we will look at, I'll get with Vanessa and Sarah to figure out when we can meet beyond June. But right now, please make sure you are holding June 26th and 27th on your calendar. That meeting will be in Rockville, Maryland. We will have an opportunity again to spend quite a bit of time and for the work groups to meet during that time. Yes, Mike.
Sorry, with Michael Warren, one thing in this, we can talk, Belinda, further about this. If the committee feels really strongly about the timeliness of these appointments and where they are with recommendations, we can talk about a communication from you that might be helpful.
Yes, do that.
To us, to remind us of the urgency of that we can use.
Thank you. Thank you, thank you. Okay, so now as we start thinking about the June meeting. Again, we will be in Rockville, Maryland. We can use whatever time we want. Right now, we're thinking travel in on the 25th, that Tuesday. The meeting will be all day on the 26th. We can also do the meeting all day on the 27th, or we can try to wrap up by around 2 o'clock on the 27th, and then quite a few people can get a flight back out. I don't know I'm coming from North Carolina, I can get a flight out about any time. So those of you who are not on the East Coast, what is kind of your cutoff from being able to get a flight out? Are you good waiting and flying out the next morning?
Yeah.
Go.
Yeah, I think the more time we have to spend together, is gonna be more helpful. So you do a two full days of meeting. That's fine. Thank you.
Others? You want a day and a half or do you want 2 days? I guess that's the bottom line question.
This is Sherry. I agree with 2 days. Yeah, this is a real pivotal time to specifically. Yeah, very valuable to be in person. In 2 days.
Thank you. Anyone have an issue with 2 days? I guess this may be the question. That includes anyone that's in. That would be our ex officios as well, or anyone that's participating virtually. So we will go with all day, the 26th and 27th.
Hi, folks. I'm just hopping back on the 26th and 27th of what month? I apologize.
Thank you, Marie. June. We'll be in Rockville, Maryland.
Okay.
And again, if you are on the East Coast, you still may be able to get out on the 27th. It's just others may struggle trying to get out. Are there specific presenters or speakers that people want to hear from at that meeting so we can start working on that agenda? We have already talked about a handful earlier. I know Charlene mentions someone to me at break. If you want to, Charlene, if you want to share that.
Thank you, Belinda. Charlene Crollinger, CDC. I thought it might be helpful for the committee to hear from someone who is an expert in systems thinking. It might be helpful to, and I can share some names of folks with Belinda and the planning group. Thank you.
Thank you, Charlene. Yes, Joy.
Joy, and I heard, committee member, I reached out to Upstream USA to see if we could speak from them, if that's okay.
Sure, I'm sure we can get a speaker from them. Yes. So we just have to think through. Yes. Okay. Yes.
Jacob Warren, committee member, we're working with the rep from CDC's Office of Rural Health to see if they could be present in June. We have a meeting in a couple weeks with this to check in with her. So we might have a rep from there as well to talk about what their new offices do.
Yes.
Versus Office of Rural Health, CDC.
No, CDC's.
Oh, CDC, yes, sorry. The Joy, and I heard again, can we recruit someone from the local DC area with lived experience to speak to us there?
Yes, I think we can. I know they have a Healthy Start site there. And so we try to make sure that is on all of our agendas. So we will work to make sure we have, you know, 1 or 2 people that can, from the lived experience. Thank you. And we already talked about the FCC or maybe someone from that perspective. We're talking about broadband. Yes, Jay. Anyone else we're missing?
Phyllis Sharp's committee member. So, you know, in that tri-state DC, Maryland, Virginia, there are parts of Maryland and Virginia that have rural populations.
Oh, okay.
So maybe those are the speakers we haven't, I don't think, lived experience. Maybe we could see if we could get some speakers from those areas.
Okay.
Particularly Western Maryland.
Western Maryland. Okay.
There's some parts of Virginia that are pretty good.
Can we follow up with you on that?
I don't know anybody, but yeah.
Well, we can talk with our Healthy Start branch to identify.
Also, the Maryland State Maternal Health Innovation Project has a huge focus on telehealth and remote patient monitoring. And they were just refunded last fall. I think they're expanding to more of those rural coastal cities. So they might be a good team to bring in.
And there's several healthy start sites in there.
I have the two thoughts. Kate Menard, I'm just going through my notes from earlier today, just making sure we've grabbed those. We talked about somebody from, and I don't know if this one's specific to the Rural Health Committee or broader cross-cutting, and I defer to you, but from the Bureau of Health Workforce. One topic that came up that I think is cross-cutting is the idea of racial concordance and building trust. I think particularly since we're focusing on racism and health disparities, that would be it. You know, a speaker with expertise on the importance of that or the would be helpful. I don't know a particular person, unfortunately. So
Yeah, under Ed's chair, we had a panel on that, so we can bring that back up just to review again. I don't believe you will. Or
I facilitated discussion.
AMA spoke.
ACGME, I think. too.
We got a nurse midwife out of New York. Yeah. Pat.
Within that jurisdiction, you've got a historically Black University Medical School at Howard University.
right.
You have a public health school at Morgan State University, is also a historically Black university, so they could be speakers from those entities.
This is Lee. We've had our Office of Epidemiology and Research do some collection of articles and published materials on racial concordance as well. And so we can provide what they were able to pull up and summarize for them. It's been a big issue with how we start and some of our doula work.
Thank you. We're filling up our agenda for June. Remember, we're gonna spend time with the work groups. Yes.
This is Sherry Alderman, and we've been talking in our work group about having the Attorney General come and speak to the document that titled, I believe, the epidemic of loneliness and isolation as a public health issue.
Thank you.
And Dr. Dawes, Daniel Dawes, Morehouse School of Medicine in Atlanta, to speak about the political determinants of health.
You. Don't get them all for June, because again, we need time for the work groups to meet. We may be able to prioritize them, and we might have to get some of them for the next meeting. But you all, I'm assuming you all have a way to contact if we're interested in the Attorney General to make that request.
Surgeon
I
General.
mean, Surgeon General. Yeah, I'm thinking, and I wrote Attorney down. Surgeon General.
Probably have a lot to say.
I wonder.
You just never know.
Michael Warren, related to that, so my read, and it has not been in great detail, but my read of that work has been more sort of general population assessments of loneliness and isolation. And so I don't, in terms of what the Surgeon General has published, are you all aware that he's published or others who have specifically looked at that? I mean, we heard it in the panel yesterday. Are there other folks who have specifically looked at maternal loneliness and isolation that we may also want to think about? I don't know if that's come up in the committee conversation. Or is it just general and we want to extrapolate to this population?
I don't know if it came up in your work groups, but I don't recall it in us talking specifically around maternal and infant health. I know that's what we're thinking, but I'm not aware of anyone that's doing work on this unless someone else knows. But it maybe we can do at least a search to see if there's someone that's written on it, on this topic area. But that's a, you know.
Hi, this is Marie.
Yes,
It
Marie.
might be helpful to reach out to our friends at ACOG to see if there's any specific materials on maternal isolation.
Thank you.
And this is Sherry again. We have in the work group talked about home visiting as an approach to addressing loneliness and isolation.
Okay. Gives us a couple of thoughts. So we have already filled up our June meeting schedule. We definitely want to reserve half a day for work. And that way it'll give you time to, meet and, have conversations and do some planning while you're in your meeting. So we'll plan for that. We'll just figure out what's the best time based on when the other speakers are available. And Sharonda dropped. Thank you, Sharonda. Yes, Jacob.
Jacob Warren, committee member, could you give us some deadlines of what you need from the working groups, like by June? What you want from us by the September, October, just to, or we could have, discussion about it, but where do we need to be to make sure that we're hitting February, March deadline,
Right, and I guess I need to really put it in writing to you all, kind of what the schedule is, because right now the only deadline I have in my head is that we need to have strong draft recommendations by the end of the year, but I can back it back up and put it at different points. So let me put that in writing, unless folks have a reason to need to know right now. But let's think about the steps in the writing process and be very clear on what that means when I'm asking you all to have a draft.
Great.
What the background is or any of those areas. Because remember, when we started down this road, we talked about making sure that we were limiting our recommendations. We were trying to come up with, 3 or 4 recommendations per work group, and we would turn it all in. So I'm thinking right off the top of my head, by September, you might need to have your long list, September, October, your long list of recommendations, unless you are immediately going directly to your 3 or 4. Because then we've got to have a period where you narrow it down. And I don't know how your work groups conversations are occurring, because I'm thinking most of you haven't even thought about what your recommendations are. You're still in the gathering phase of trying to come up with, well, what do we think we should focus on and what to improve African-American Black infant mortality and maternal morbidity and mortality. So let me put it in writing and get it out to you all in the next 2 weeks.
As Kate Bart, I'd like to just put a plug in for advanced scheduling. June 26 and 27, clinical schedules are made, and this is, so it's then, so it's going to be some jumping through hoops, but if we can get September on the calendar, that would be really helpful.
Right, and I can't remember, we sent the June dates out February, but that may not have been enough notice. I'm trying to remember when we sent it out.
That's always the goal. Yes.
It's a lot of calendars that we have to think around.
I understand, but I'm.
Right, if we're gonna do September, October, we should be able to get that out soon, very soon. We'll meet next week.
We can.
We'll start.
Yes.
And we'll start looking at calendars. Yeah. We should be able to get the dates out for the rest of the year. Because we just need to figure out if we can do 1 more meeting or 2 more. One can be virtual and one can be in person. I understand, Kate, because I'm not a clinician, but my calendar feels.
I know, I'm not. I didn't mean to apply
And
that.
Marie,
Sorry.
Marie has put in the AAFP annual meeting will be September the 22nd to 26th, so she will not be available. If you know you're not going to be available the rest of the year, just drop us a little note.
Not for the whole year.
Only have excuse absence and say you have to be at this other event. Any other thoughts, concerns, suggestions around the June meeting? Oh, yes. Oh, well, we can broaden it. Any other thoughts or concerns in general? Yes, Sherry.
This is Sherry Alderman. I think this has been a really fabulous, good use of time here today, and the speakers were incredible, and to be able to sit together around the table and work together has just been really phenomenal. And I want to thank everyone who worked so hard to make this so successful, and to have representation from more than representation, but actually colleagues and champions for this work at the table is really very valuable and gives me a lot of inspiration and a lot of hope. We have focused over the last 3 days, we've focused very much on maternal health, which is critically important for the issues that we're faced with in this country. We have, and certainly when I think about the babies, the maternal health is, and fathers as well, is really, really, really critically important. We also know from an infant mental health perspective that when we address the issues with maternal health, associated with maternal health, there's still a baby who has been impacted, and the baby does not automatically get fixed when we fix maternal health. And so there are so many factors that play into the mental health of a baby and young child, and one is the health and well-being of those adults who are with that child and care for that child. They are very much impacted, more so than the adults, psychologically, behaviorally, physically, in an environment of adversity, and that there is certainly an opportunity for repair. But that really needs to be intentional. And one thing that I was sitting here thinking about is about half of the infant deaths due to child abuse or neglect is an issue of infant mortality that we haven't touched on as just one example when we think about it from the baby's perspective. And so I don't know where I'm going with this. I still have a lot to reflect on to be able to have a direction, but I don't want us to forget about the babies, as we're really working so hard to address these huge issues. And I just appreciate the opportunity to express that.
No, thank you, Sherry. And just know that when Sarah, Vanessa, and I were meeting to plan, we were trying to make sure we had presentations that included a focus on both. Hence the reason we definitely want a Healthy Start, because their primary focus is on improving birth outcomes, but it includes maternal health as well. But we wanted to have the Black Infant Health Program from California come and present. And something came up, they just couldn't get permission that quickly. So we will probably have them down for June. And if there are other areas, programs that you all are aware of and you want to hear, there's some lessons learned or something related to Black infant mortality, let us know, and we'll definitely feel like adding them on. But you're right, it seems like since we've changed the charter to talk about maternal health, we have inundated it with maternal health, realizing that most of us know it's the infant and the maternal, it's the diet working together. But thank you for your feedback on it. Keep us honest. Maria, I see your hand is up.
I'm glad you brought that up, Sherry. I think the March of Dimes would be a great resource to help with connecting with neonatal mortality, morbidity. I can share a contact of one of the leading neonatologists that work very closely with March of Dimes and has worked on several campaigns with them. And that might work well for our committee purposes to hear about their work.
Thank you, Marie. If you'll drop it in a chat or send us an email, that would be good. And Sherry.
And this is Sherry again, and also Alicia Lieberman is a huge figure in the world of infant mental health and has developed over the decades of contributions that she has made to that field, a evidence-based approach to addressing and prevention of transgenerational child abuse. So she might be a potential speaker as well.
And you've got her
put that-
contact if you'll drop it. Thank you. I know we're getting ready to start losing people. So as we are wrapping up, I do want to give everyone a chance, if you like, don't be forced. If you've got any closing thoughts, anything that resonated with you deeply during this meeting that we've been able to have in person, we cannot thank the people of St. Louis and Missouri enough for welcoming us here, laying out the red carpet for us. They have really been awesome to work with at every level. And who could have expected that we would be in such a beautiful space that has so much rich history that talks about, some of the challenges and the divides and the history of why we're dealing with some of these issues still today. So the fact that they, again, opened their arms to us. I don't know if any of them are still here, but we'll definitely send them a nice thank you note back.
Some of them are still online, I think.
Some of them are still online. We'll send something in writing back just to thank them. But anyone have anything they want to share as we wrap up?
Steve Calvin, committee member. I'd also like to just thank Sharonda. She was kind of our local host. And for me, this was really interesting because it was a walk down memory lane. And it was very enlightening. And I'm really grateful to be part of this group.
Thank you, Steve. Anyone else like to chime in? Yes, Marie.
Hi, Marie Ramos. Wonderful meeting, everyone. And albeit I was remote, was very much enriched by all of the thoughtful presentations and subject matter experts. Something that was very striking to me is, again, how do we create and bring new and refreshing information as it relates to maternal health, Black maternal infant health, as this has been unfortunately a lasting cry for many, many years. One of the things that I believe we have an opportunity in is helping to bridge a gap of perhaps more traditional ways of looking at maternal infant health, Black maternal infant health, and providing a fresh perspective and different lenses that perhaps the secretary and our federal government has not yet been able to incorporate. And hearing particularly the stories of our community members and the wonderful work that they're doing, I see a lot of potential on providing salient examples of integration of both traditional and culturally sensitive approaches into this medicalized space that we've created for our birthing people and the children that they birth. So I'm really encouraged to take a look at this in the lens of what are some potential programs, offerings that potentially the secretary can help promote and enhance as it relates to populations of priority, but specifically for our Black population within the United States. Again, I see the work that we're doing here as a stepping stone. Very often in our American history, the plight and the work that's done for, with, and on behalf of our Black community members often bleeds over into other minority or historically excluded populations as well. And so I take this work very seriously in the sense that this could, the work and the recommendations that are provided to our secretary could very well be an impetus to creating more intentional policy that can not only affect Black maternal infant health and the crisis that we're facing, but other communities and populations that have been historically excluded. So I am refreshed, I'm reinvigorated, and I thank you all for sharing in this space with me.
Thank you so much, Marie. Sharonda?
Hey, I just want to say one thing. One of the common threads for every board that I've sat on, every cabinet that I've sat on, one of the common threads that I hear a lot, even here, is educate, educate, educate. And the only thing I want to kind of bring for us to think about, to think outside the box, are we educating the right people, right? Should that burden be on the patient to be educated in order to get the care that they deserve? That's just something that I think has to be brought to the table and shed light on, because is it really truly fair that the only way that they can get the care that they deserve is if they're educated in something it's really not something that they should be familiar with, unless that's the role that they want to play in life, right? If they want to be in the medical field, then yeah, then they'll be educated in that field. But to say to a patient, oh, you didn't get this type of care because you didn't know it existed, it's something that we have to all think about.
Thank you, Sharonda. You know, we always appreciate your feedback. Thank you. Anyone else? Which one?
It's Michael Warren. I just want to thank, I appreciate some of the community members acknowledging, but I want to reiterate the thanks for the intentionality that went into planning from our team, and in particular, Vanessa and Sarah. I think it was reflected in the panels that we heard from, and really appreciated the panelists commenting on the approach of asking them how they wanted this to go, rather than sort of coming in with assumptions, and really recognizing the wisdom and the lived experience. So I just want to acknowledge them for this work.
Want to cut anyone off? Yes, Vanessa.
Okay, well, then, thank you, Dr. Ward, for that. And we couldn't have done it, obviously, without Sharonda, as others have said, being the local. She really did give us suggestions and recommendations for many sites that we were considering. And then she connected us to Generate Health, who is a tenant of this building. And Kendra and her team at Generate Health just did a really nice job letting us know who the local players were, including the two health departments, and did a really warm handoff for us to Dr. Mahdi and Dr. Cunningham. And it was through them that we found even more local organizations, as well as two of the speakers with lived experience, and then Generate Health and Healthy Start, of course, contributed as well to that panel. So it was a team effort, both, our team back home and the team here in St. Louis, and of course with our chair, Belinda, all of the support and input she gave the agenda. And then last, we really modeled it off of the work that had been done for the tribal meeting. I mean, we saw just how successful that was in September 2022 in Minneapolis. So we didn't feel like we needed to recreate the wheel. So just want to credit Dr. Ellinger, Janelle, Magda, and Belinda, and those that had rolled off for their work on the creation of that agenda, which we sort of modeled this one off of. And last, just thank you all for making that recommendation to us to have these meetings in the community, into the communities that we're actually discussing. And if you want to reemphasize that in your next set of recommendations, we would
Consider
it away.
No, I want to thank everyone for all the time and energy and the thought that you put into this meeting and for everyone being willing to listen. You know, we come to St. Louis to hear from the community, to hear from a part of the community that doesn't always get the opportunity to have folks, you know, come in and listen. And I think we would do a disservice to them if we're not listening to the recommendations that they shared with us, as well as many others. This has been a joy to work with this group. Sharonda was awesome right from the beginning. When I reached out to her, I said, Sharonda, are you good if we come to St. Louis? And she said, St. Louis? I said, yes, St. Louis, you're home. So she was wonderful right from the beginning. And then just after very short meetings with Vanessa and Sarah, they ran with it. But it was awesome to have, you know, Generate Help and all of the other players. We had really no one that's told us no. People found out, you know, they found out we were coming and they moved heaven and earth to try to make sure we could be where they thought was best for us to be. And I think it was demonstrated in everything that was done. So thank you all so very much for your ongoing leadership, your time, your commitment to move this work forward. It is not easy. Please take care of yourself. Don't forget self-care in the midst of all of this. As we tell others all the time, you know, we have to remember to take care of ourselves. So as we bring this meeting to a close, we say thank you to all of those that joined us virtually. We miss giving you a hug in case you weren't able to be here in person because Belinda is a hugger. But otherwise, we look forward to seeing you hopefully in Rockville or in virtual land somewhere. Thanks, everyone.
Thank you all so much.
Many thanks.
Thanks. In the chat, please complete a form if you need to.
Yes, our final announcement. We are gonna,
Final announcements, okay.
yes, the not fun stuff. Please, by May 15th, complete your ethics forms. You should have received that on Monday from Shindell.
Saw it, thank you.
Your annual, so the new round just came out that are due in May.
Time to pick